Welcome to AETCM Emergency Medicine Channel. Shall I start, sir? 63-year-old male patient presented to our ER with early history of deliberate self-harm who consumed brand name Sweep Power, which is a herbicide, glufosinate ammonium, synthetic organophosphorus compound for which was used for his agricultural purposes. He consumed an unknown quantity of the bottle mixed with...
poisoning is not herbicide. No? Herbicides are different.
Different insect.
Herbicides to kill the plants. This is pesticide. Comes under pesticide.
Unknown quantity of the bottle.
Herbicide action and their toxic effects are entirely different. It mainly affects the lung. All these things.
Synthetic organophosphorus compound. Unknown quantity of the bottle mixed with the water at around 12:30 p.m. followed by 2 episodes of vomiting and 1 episode of loose stools and cough associated with chest discomfort. At that time, the patient taken to the outside hospital. In the outside hospital, they done gastric lavage and 2-pint normal saline bolus given. And at
what is the current guidelines of gastric lavage?
You're using the large within 1 hour. We have to.
So ideally, it has to be done within 1 hour. That is the current guideline. If it is
delayed gastric motility and if it large quantity is consumed.
Quantity and sustained release tablets, all these things you can give for extended time.
Okay,
otherwise 1 hour is the normal time, what we read in books. Sometimes we'll have to use it after some time also. Suppose the patient has taken with alcohol, the motility will come down.
And 2-pint NS bolus given, and during the hospital stay, the patient had already 1 episode of vomiting and loose stool, and also there is a history of alcohol intake in the morning. Patient regularly use alcohol in the morning time, and they shifted the patient for further management here. While receiving here, we wear protective measures with gloves, and after that
why should we wear protective gloves in OP poisoning?
Since OP poisoning has the skin
transmission through skin. It's very common and it can produce problem to the healthcare professionals.
We wear protective measures with gloves and we triaged in the area. Initially, on arrival, the patient airway is patent with no secretions. Breathing is saturation is 100% with 6 liter O2. Patient is on face mask with respiratory rate of 24 per minute, and chest was clear at that time. And the heart rate is around 80 per minute with BP 130/100 and peripheral pulses are palpable. On disability, GCS is E3. V5 M6.
Can this one penetrate CNS? OP poisoning? Okay.
And we found a kerosene-like smell, and we shifted an exposure.
What we read normally?
Garlic powder.
So that is actually it's normal. It is not garlic smell. It is a kerosene or petrol-like smell. What you experience normally. Okay, but standard textbooks still give it's a garlic smell.
And on exposure, patient is febrile, no external injuries. We directly taken the patient to the decontamination room. After that, we exposed the whole body and removed the clothes and kept it in a plastic bag separately for analysis.
Why should we remove the full clothes and wash the body? Why should you keep it in a separate place and secure that clothes?
Once we have to send it for toxic analysis, and also it is a hazardous material.
Okay.
So we have to keep
and you have to remove and wash it properly. Otherwise, from dress itself again it can reabsorb. That's why we are removing and keeping it. And since it is a medical legal case, that has to be preserved.
And thorough wash with soap and water, including the scalp, skin, hands, face, and skin creases. Everything we wash thoroughly.
Ideally, it has to be in running water, not soap and water. Soap is not going to do anything, but water has to be poured into the patient body and clean it with water alone. Continuous water flow is required for all these things.
Okay. After that, we shifted the patient to the main ER. Since the patient is already crossed the 1 hour, we reassessed we didn't do gastric lavage at that point. And we reassess the patient, and on reassessment, GCS is full, 15/15 with chest. We got bilateral crepitations, bronchoria present. So we started on injection Atropine at that point, 1 to mg 1.2 mg IV stat given, and after that
1.2 mg.
1.2 mg.
That means how many ampules?
One vial is 0.6.
One ampule or vial?
One ampule is
Ampule is
0.6.
0.6 mg.
One vial is 100 ml.
100 ml is equal to
1 mg.
1 mg per ml. So that is it's a major difference from ampule to vial. That you should remember. Ampule is, some countries it is 0.5. In our country it is 0.6. Whereas vial is 1 ml contains 1 mg. Okay.
Initially we give 1.2 mg.
The recent ACLS guidelines all tell 1 mg in most of the conditions. Previously it was 0.5.
And on reassessment after 5 minutes, there is still crepitation. So we doubled the dose and injection atropine 2.4 mg we given at that point. And we also started on Oxime, parallel Oxime injection.
So tell me about atropine bolus doses and atropine infusion difference. Is there any difference or all same in OP poisoning? You tell all these things. What is the main difference between bolus dose and infusion dose? What is the difference? Why?
We can keep it short acting.
Continuously in order to it will be going.
But OP poisoning?
We need to
Is there
reduce
any
the
difference?
secretions.
Is there any difference or not? Bolus dose means you repeatedly give 1 ml every 5 minutes or 10 minutes or half an hour, 1 hour, like that you can decide. Infusion is continuously flowing with an infusion pump. Is there any difference in OP poison or not? I am asking. It is not going to give any benefit whether you give bolus dose or infusion dose. We all learned that atropine is a short acting drug, but it is only for the heart. Suppose you have a severe bradycardia and because of that patient develops shock, then you can continuously infuse the atropine because it's a short acting drug. But for secretion sake, if you are giving, that is the most important thing. Whether it is bolus dose or infusion dose, it's all same. But heart rate is very low means you have to give infusion. That is because atropine is a short acting drug. So we cannot try any chance there. You continuously give infusion.
And after the second, we also started on Oxime, parallel Oxime, which is 30 mg per kg initial dose IV bolus. So we give 70 kg patient 2 gram IV stat over 30 minutes and followed by we started on 8 mg per kg per hour infusion. And on after giving the second dose of atropine, chest became clear at that point. And after on reassessment, the patient has worsening of GCS and irregular respirations with the myoclonic jerky movements in the upper limb and lower limb. So that we intubated the patient with the endotracheal tube of size 8 centimeter.
So what are the indications for intubation in OP poisoning? You already told, that's it, but I am just asking.
There is lower GCS.
Lower GCS is the most important reason.
And there is bronchoria, increased respiratory secretions,
ARDS
chances
like
for
features.
to aspirate and ARDS.
Third one also you told, but you didn't. I think you didn't understand
respiratory muscle paralysis, stands for respiratory muscle paralysis.
So fasciculations you have told already, twitching, fasciculation, that all indicates element type of nerve involvement. Phrenic nerve also can be involved. So low GCS, lot of secretions with muscle twitching, fasciculations and respiratory distress. All these things are indication for intubation in OP poison.
And after the intubation, we continued the atropine and pralodoxam infusion, and we monitor the heart rate, BP, check for the crepitations in the chest, and we also check for
you have when you are monitoring, what all things you monitor in OP poisoning?
We have to monitor the heart rate, BP.
One is heart rate. Heart rate should not go down. It should be above 100 or 120. That's okay. Then
BP monitor.
BP why should we monitor? Anybody's hypertension that we are preventing and we are watching it. Then
check for any crepitations in the chest.
Okay, secretions in the chest which is producing crepitation. That is the most important. That also we monitor. Then
check for hyperthermia and
hyperthermia
agitation.
is not a direct feature of OP poisoning. But it can occur due
after
to
starting atropine.
atropine can produce increased temperature.
Any agitations.
Agitations also
seizures.
can be produced either by atropine or can be due to OP itself. Then, so here you are already intubated, so muscle twitching has got no other relevance because we are already intubated. Otherwise, we have to monitor the muscle twitching, all these things, because that is also a sign of deterioration of patient. Okay.
Before starting atropine, we also catheterize the patient.
Okay. Why should be catheterized?
Atropine will cause a sphincter contraction,
Okay.
and
In
it will
elderly
be difficult.
individual, patient can develop urinary retention after atropine. So better to catheterize first itself. Should we put a rice tube and start feeding?
Initially, there will be decreased motility, so that we should.
So better to avoid feeding during the acute phase because motility will be reduced, and there is a paralytic ileus, possibility of paralytic ileus. If that is not there, you can feed the patient. All these things are supportive measures, but they are very important. Okay. Like suppose you don't know about this and you start feeding the patient can aspirate. He can vomit and aspirate.
And we shift the patient to the ICU or ICU for further management, and we monitor these things. Just about the which are the symptoms of the.
When will you stop atropine? What are the alternatives for atropine? When will you stop pralidoxin? These things are important.
Pralidoxin will stop after 24 to 48 hours.
48 hours you can stop, or after 48 hours patient is coming, no need to start. If it is carbamates, you no need to start. All these things are important. But atropine, when will you start? So starting you did. When will you stop? When will you alter the regime?
If the patient is agitated and there
the
is chance for
patient is
atropine
agitated
psychosis.
and shouting, you have two differential diagnoses. One is atropine poisoning, toxicity, or because of OP poisoning. How do you tackle that issue?
We can reduce the dose of the atropine and add glycopyrrolate, which does not cross the blood-brain
So you can still continue the atropine in some patients with glycopyrrolate, or you can completely stop atropine and replace with glycopyrrolate. Only thing, OP-induced CNS effects cannot be treated with glycopyrrolate alone. That's why most of the patients you may have to mix both. You have to continue atropine in a lower dose that will act on the brain, but it will not produce toxicity, and continue glycopyrrolate to act on the peripheries. So what are the basic differences between atropine and glycopyrrolate? One is it will not cross blood-brain barrier. Other things? Heart rate, which is better to increase heart rate? Atropine is better. Secretions, which is better? Glycopyrrolate. So these are the basic differences, but ultimately they are not going to make any clinical difference. Only in the altered behavior, glycopyrrolate will be a better choice.
And atropine can be
Dose
stopped.
of glycopyrrolate, how do you calculate? Actually, we are wasting our time how to calculate. You give the glycopyrrolate same like atropine, 1 mg means 1 mg. If it is more, it will produce toxicity. If it is less, secretions will increase. Okay. So there is no point in calculating how to compare with atropine and glycopyrrolate. So there is no comparison like that. But normally we give 1 mg atropine means we assume that 1 mg glycopyrrolate may be equal. We exactly don't know whether it is equal or not. But we give it like that. Suppose it is lower dose, it is not producing any effect, increase the dose. We are giving anyway infusion. Okay.
And we can stop the atropine if there is dried up lungs. With
So atropine toxicity is one condition where we have to stop it and switch to glycopyrrolate. Otherwise, secretion has to be dried up completely. So this patient is intubated. How do you know that secretions are dried up?
Auscultation.
Means auscultation, when you aspirate through the tube, when you aspirate you get lot of frothy secretions in OP poisoning. That is completely dried up, then there is a possibility of lesser secretion, but auscultation will be the only possible thing in most of the ICUs, and you can take a chest X-ray and see that ARDS like findings are there or not. What happened to the patient afterwards?
Afterwards, the patient get better and extubated when the patient comes into full GCS and spontaneous breath.
Okay.
When patient came with or OP poisoning, we can look for the signs and symptoms of the OP poisoning. Like OP, primarily the presynaptic neurotransmitter at the nicotinic receptors in sympathetic ganglia and adrenal medulla. So at that time there will be sympathetic stimulation will be there, which shows us pallor, mydriasis, tachycardia and hypertension will be there. It has also parasympathetic action on the nicotinic and muscarinic receptors. If it is acting on the nicotinic NMG receptors, there will be muscular fasciculations, cramps, and later change into muscle weakness and finally to the paralysis. And at that time there will be difficulty to detect the seizure activity, finally to the respiratory muscle paralysis.
Main thing is pulse rate. Normally what we learn in books is OP poisoning means bradycardia. That is a toxic drop. But 20% of the patients who take OP can have tachycardia due to nicotinic action. And you give at some patients may be coming to our hospital after taking atropine or something, or alcohol, that also can produce this one, or nicotinic action can also produce. So 20% of the patients who is having OP poison can have tachycardia. That you should remember. But we learn standard textbooks or toxidromes, it is bradycardia. Bradycardia, pinpoint pupil fasciculations and lot of secretions.
And in muscarinic, we have a mnemonic like dumbbells, defecation, urination, meiosis, bradycardia, bronchoria, bronchospasm, emesis, lacrimation and salivation. And it is known as killer bees, like bradycardia, bronchoria and bronchospasm. And that mainly may be due to failure, due to respiratory failure by bronchoria and respiratory muscle weakness. And it also manifests as abdominal pain like pancreatitis and peritonitis, and aspiration of the gastric contents and HC solvents, hydrocarbon solvents within the preparation. There will be chance for lipoid pneumonia, and that lead to respiratory failure also. And early stages of severe toxicity, there is chance for myocardial ischemia also. And OP poisoning can manifest as acute toxicity, and it's also present at intermediate syndrome. Intermediate syndrome, 1 to 5 days after exposure, mainly there will be paralysis of the neck flexor muscles innervated by the cranial nerves, and also there will be proximal limb muscle and respiratory muscle weakness.
So it is all due to the resecretion from the stores of the fat. It will be resecreted to the body and it produces all symptoms. How do you treat that? Atropine. There pyridoxine is not required, only atropine is required. This because of there is a process in the body that is called as aging. So aging happens for all these things, so there is no point in treating after that time.
We can prevent this by aggressive early antidote therapy and supportive measures. And in chronic toxicity that is seen in agricultural workers with daily exposure, they will present with symmetrical sensory motor axonopathy.
So how do you diagnose it? Many patients with heavy poisoning also can present with peripheral food drop.
Foot drop.
So foot drop. Every day you have to check for foot drop. In ICU, if the patient is having foot drop, you should understand that may be a heavy poison, or a patient may be chronically exposed to OP. That's why this peripheral delayed polyneuropathy is occurring.
OP-induced delayed neuropathy, there will be cognitive dysfunctions, impaired
memory. Any other poisoning can
changes.
produce foot drop? Lead poisoning. Lead poisoning is other common. It is nowadays it is not common. That also can produce peripheral neuropathy. Carbamates? What about carbamates? They are related components.
In carbamates, pyridoxine will not be...
Pyridoxine is not required, or sometimes it can produce adverse effects. Atropine can be continued. Should we use antibiotic for this patient? That will
if the patient is in ICU admission and there is chance for aspiration pneumonia or the ventilator associated
pneumonia. When you intubate the patient, there is a chance of ventilator associated pneumonia. So to prevent a ventilator associated pneumonia, you can start some antibiotic depending on the bacterial flora in your ICU or in your hospital, but not a general recommendation. What else you advise to the patient? Can the patient take oral feeds? We already told. The patient is taken an X-ray abdomen. There is no obstructive findings in the X-ray like gas or fluid levels. Then patient can take oral feeds. Okay, thank you.